Okay, we've talked about the pain aspect and how a woman, maybe on her own and certainly with the help of her gynecologist, can find answers to the pain. And for the vast majority of women, that is something that can be treated. So, talk then about the interest, or as many women will call it, sex drive. Just back to the connection there, and what as a physician you can encourage or talk about on that aspect of her sex life. Can sex be good after menopause? I'm Dr. Carol, and that is a topic more women ask than you may realize. It becomes an issue for essentially every woman that goes through the midlife transition, which is 100% of us. Now, many of you know I've been an OB-GYN for going on 30 years now, close to it. And this topic of the biology of sex and how that changes at menopause and how the experience changes and what to do about it is something that I know many women struggle with. Well, recently, my friend and I, Dr. LisaSavage, were part of a conference we did on women's health in midlife. And this was a topic that the women who were there wanted a lot more of. So I got Dr. LisaSavage to join me on this episode to talk specifically about sex and menopause. Dr. LisaSavage has been an OB-GYN physician for over 25 years. She got her training at Baylor College of Medicine and Emory University, has practiced in Austin, Texas for about 25 years until very recently, and now is doing online consultations and telemedicine with Genève. Gynecology has been the focus of Dr. Savage's career all along. Not so much the OB side, but helping women with the gynecology aspects of their lives, and dealing with sex and sexual issues around menopause has been a significant part of what she has counseled women about and is doing so now. I know that this conversation with Dr. Savage will perhaps open your eyes to what is possible, what's normal, and what can be done to make things better. Yes, you can have a satisfying, pain-free, and enjoyable sex life even after menopause. So, especially for women in midlife or for the men who love them, this will be such a helpful conversation. Dr. LisaSavage. Well, Dr. LisaSavage, you and I have known each other for some years now, and it is a great pleasure to have you with me on the program today, talking about some stuff that women want to know. Just thank you for being here.
Thank you so much for inviting me. It's a real pleasure to talk to you and talk to your listeners about things that women want to know about and might be hesitant to bring up.
Yes, and let's just start with that. The whole area of sex, sexuality, menopause, hormones, they're related, but especially the sexuality part. That's something that, yes, women want to know, but they struggle to know how to ask. And I just have a feeling that some try to ask their OB-GYN doctor and may not kind of get the response that is really particularly helpful. But you have been talking with women about these intimate matters for many years, in practice for 25, 10 to 15, specifically gynecology, and now you're working specifically with women in this season of life. What have you seen about the hesitation, the things they want to ask but aren't sure they can? Let's just make that okay for a minute.
Let's do. All right. So this is what I call the hand on the doorknob syndrome. So that when I'm just wrapping up with a patient, usually for her annual preventive care, and I'm about to walk out of the room thinking we're finished, and I have my hand on the doorknob, she'll say, "Doctor, there's one more thing." And so then I say, "Okay, what's that?" And meanwhile, we're out of time. And what I usually do is I address it and say, "Oh my gosh, I'm so glad you brought that up." It needs its own dedicated time. We've got to really focus on this. So I would like for you to make an appointment to come back, and that's the only thing we're going to discuss.
Yeah.
And I want to put it out there for women, patients, that this deserves an entire appointment of its own. Don't try to tack it on to your annual exam. Don't try to tack it on for an acute visit for something else. Your doctor's attention and focus for this particular problem will be there if you make it a focused appointment. I call it a problem-focused appointment. I think that's really important because we want to help you. We want to give you all this great information. We want to listen. And if you give us the chance by making that separate focused appointment, we can do that. If my hand is on the doorknob, my mind is already on the next patient and I thought we were finished.
Yeah.
So I think it's a struggle for physicians, and a lot of women complain about being dismissed. She didn't have time, he was rushed, you name it. But part of that is because it's brought up in the context of a visit for something entirely different. Yeah. And we multitask a lot. We keep a lot of windows open, but we really want to focus on you, the patient. We really want to focus on this problem. We need a dedicated time for it. So keep that in mind, and you'll get a much better experience around asking about this issue. That said, please bring it up. Please bring it up, even if it's in the context of your annual, so that we can validate that and we can invite you to come back so we can dedicate time for it. Your gynecologist is absolutely qualified to help you with this. I do want to, and I love my primary care colleagues, and I could not do what they do. But I really think that all women need both a primary care physician and an OB-GYN or gynecologist, because we're usually better equipped, better trained, more comfortable talking about these issues of sexuality. Now, I have some primary care colleagues who are awesome in that regard. They welcome it, but more often than not, they're busy taking care of hypertension and thyroid disease and you name it. And so again, go ask of the right person. And I think you'll get a better experience. But the bottom line is, please bring it up.
That is so good. That is so good. As a gynecologist, what are some of the typical concerns that end up being the reason a woman wants to talk to you about these matters?
Usually it comes up with what women will call sex drive. Mm-hmm. I've lost my sex drive. Can you help me with my sex drive? And the first thing I do is say, oh, absolutely, I can help you. But I don't call it drive in women. I call it interest or receptivity. Drive is more of a male trait. It's not that we women don't feel driven. Sometimes we do, usually in our earlier phase of life, the reproductive years, when we're ovulating. But I want to set expectations and normalize the fact that most women don't have drive per se, but rather interest, right? We're female, we're feminine, and we're interested, or we can be aroused, or we're receptive. Usually it comes up in that context. Help me with my sex drive. And so the first question I ask with that concern is, does it hurt? Does it hurt when you have sex? More often than not at midlife, the answer is yes. But a woman doesn't come, it's interesting, she doesn't present by saying, it hurts when I have sex. She says, my sex drive is lower, or I don't have any. And it turns out that it's because she's having pain with sexual activity. The outer tissues, called the vulva, the inside, called the vagina, is painful. It hurts. And I always ask, well, who would want to have something that hurts? Who would be interested or driven to do something that is painful? The answer is nobody. And so that's how it comes up, usually about interest or drive. And then we ask the right questions from there, and we get to the rest of the story.
Yeah. With the hurt, with the pain, and knowing that we're talking largely to women in the middle portion of their lives, just biologically, help our listeners and viewers understand what happens in midlife that can lead to it hurting when sex may not have hurt before. The vagina may not have been, irritated or itching or whatever in that way.
So true. So what happens at midlife and even before in perimenopause, it can start as early as your late 30s and on into your 40s. early to mid 50s and beyond, is that the ovaries start to fail. They start to produce less and less hormone, principally estrogen and also progesterone. And the tissues of the female genitals, the vulva, the vagina, also the urethra that leads to the bladder and the bladder, are all estrogen sensitive tissues. And when they are estrogen deprived, they tend to atrophy, in other words, shrivel. I hate that word.
But I do too, but just to let women know, it happens to everybody. It's
it happens to everybody.
It's just a description of what happens.
And so actually the American Congress of OB-GYN, in the interest of nice semantics, has gotten rid of the term vulvovaginal atrophy, or VVA. We have a new term. It's called GSM, genitourinary syndrome of menopause. And so what we're talking about is GSM. Estrogen deprived tissues get thin, dry, less elastic, more fragile, more prone to infection, vaginal infection, bladder infection, you name it. And the tissue thinness and dryness and lack of elasticity can even lead to cuts and bleeding, friction. Women will say it feels like sandpaper. And it does. And I sometimes on examination, I'll tell the patient, it looks like the Sahara Desert down here. And we both get a little chuckle, but it takes some of the seriousness out of it for the patient and lets me kind of connect and make it more comfortable. But that's what it feels like. It feels like a desert. It's desiccated, it's dry, thin, fragile, and prone to, a lot of injury and infection, et cetera. So that's the description of what happens in the absence of estrogen, which happens to 100% of women. The average age of menopause, or full cessation of periods for a year, is age 51. It can start before then, and it gets worse after that. It is progressive. The good news is we can do some things about that.
Yes. Well, let's talk about some of those things. You already alluded to that the reason for GSM, this syndrome, is the lack of estrogen. So I would assume estrogen is among the top options. Talk about that.
It is among the top options, and I'm a huge fan of vaginal estrogen. But to back up from that, there are over-the-counter products that are vaginal moisturizers for daily moisture and or lubricants to use with intercourse.
Good.
There are some products that serve the purpose for both. There are some products that are just for daily moisture. And those can be really effective. You have to use them regularly. They do treat the symptom, not the root cause, but they can be very effective. And some women who either can't or are shy of hormone therapy will find great success with some of those over-the-counter vaginal moisture and lubricating products. So that's sort of the first step. The next step is vaginal estrogen. And I'm telling you, ladies, it is a game changer. We can restore the vagina. I cannot make you 25 years old again, but I can make you the best at your current age that you can be for function and comfort and sexual satisfaction. And replacing what the ovary is no longer making for the vagina works beautifully. The most wonderful thing is that almost every single woman can use it. It is safe. It can be used indefinitely. Breast cancer patients are absolutely able to use it. And this is why. Vaginal estrogen is local therapy. It is not absorbed to any measurable or clinically significant degree into your whole body system. If you take two women, one of whom is not using vaginal estrogen and the other of whom is, their blood levels of estrogen will be the same. It's really not absorbed to any measurable degree. So that's the happiest news I can say, is that it can really restore the tissue function, quality, receptivity, you name it. It can be used by almost all women, and it can be used indefinitely.
Yeah. So we don't have to be afraid that the breast cancer risk that is controversial, but that's for another day, with hormone therapy or the impact on, bones or heart or brain or whatever, that is a separate conversation. For GSM, for discomfort with sex, vaginal estrogen can be a game changer. I love that. Does
Absolutely,
that do
absolutely.
anything to the risk of infections, bladder infections or vaginal infections? Is that impacted?
It is greatly impacted because those tissues, being estrogen responsive, estrogen dependent, become less able to be a barrier to infection when the tissue is thin, dry, and fragile. So bladder infections, urinary tract infections of all kind, including kidney infections, vaginal infections are all more possible, or more women are more prone to them in the absence of estrogen. So if we replace it vaginally, those tissues will plump up, they will become more moisturized, more resilient, more of a barrier to infection of both the bladder, urinary tract, and the vagina. So absolutely, that can really decrease the incidence of all those infections.
What about women who are concerned about using something synthetic, that this is foreign to my body? Talk about that when it comes to vaginal estrogen.
That's a big topic these days. You know, there are a lot of terms out there: bioidentical, compounded, synthetic. There's no difference in those products in terms of the safety or effectiveness. What I call the risk profile is the same whether it's synthetic or happens to be bioidentical. And there are FDA approved conventional products that happen to be bioidentical. To me, it's neither here nor there, whether it is or isn't. And again, these products are just local products, are not absorbed systemically. And I think that really reassures a lot of women that it's not a systemic effect, no matter whether it's synthetic or not synthetic. It's not absorbed systemically, very safe.
Yeah. Let's talk just briefly about a couple of the other medical things that are out there. I know there's a couple other, medication options, and there's also this laser, option that in some circles is talked about. Your perspective on that?
So there are a couple of other medication products. One's actually a pill you take by mouth. It's called Osphena. And just to say, I don't have any conflict of interest with any of the products that I'm talking about. But that is a pill you take by mouth, and it preferentially improves the vagina. We don't think that it has adverse effects on other body systems. I'm not a huge fan of it. Some doctors love it. Some patients love it. I had a couple who really did because they had trouble with a vaginal insert. So that's one option, is the pill you take by mouth that is just for the vagina and doesn't result in adverse effects in your system. There's another one that's DHEA, another hormone. It is a precursor to estrogen, so it gets converted to estrogen. And so that's an option that's out there. That one is definitely safe in breast cancer patients, although I said that the vaginal estrogens themselves are too. Just to say one more thing about that, the American Congress of OB-GYN and then the North American Menopause Society both endorse the use of vaginal estrogen, even in breast cancer patients. That said, there are these other medication options. Now, on the laser therapies, I was approached several years ago when the first one of these, it's called Mona Lisa, came out. They approached me as having a small, well-established practice in Austin, and they wanted me to be sort of one of the first users of this technology in Austin. And I was intrigued, and I said, well, tell me more. Show me the studies, show me the data.
Yeah.
And they showed me what they had at the time, and it was minimal, skeletal, like a study with 5 cases. It was just not ready for prime time at that time. Now, since then, we do have more data, more experience. My own gynecologist uses it. I would trust her to use it on me. We don't have super long-term data, and that will be forthcoming. I think probably these technologies will eventually have all the data we need to be entirely convinced. But especially for women who do not want to take medication, or for whatever reason they cannot, I think these therapies really do have a place. They've done some head-to-head studies between vaginal estrogen and these technologies with laser, and they look pretty comparable. So that's good. That's good. And of course, you could use them both together as well. So again, it's newer technology. We don't have a real long track record with it, but I think in the right hands, we probably have enough not to be afraid of it if it seems like the right thing for you. It is not covered by insurance. It tends to be expensive. You tend to need several treatments over time. So, I think for certain patients, it's probably a good fit. One thing I would add to that, though, is that I would only see, personally, I would only see a gynecologist who was offering it, because there are some physicians in other specialties who have not wielded a speculum their whole career the way we have, who offer it. And so my bias, my personal bias as a gynecologist, full disclosure, is that I would only see a gynecologist for the application of this technology.
Yeah. I have heard, and this is not something I have ever been trained in or used myself, for those of you who know that I have been an OB-GYN, but kind of the chatter that I've seen about it is the way it is supposed to work is that it increases the blood supply to the vaginal area, and therefore with increased blood supply, it improves the elasticity and the thickness of the vaginal walls and so on, because of the impact on blood supply. It's an intriguing idea.
It is. It creates little micro trauma in the vagina. And as that heals, you get collagen and elastin and increased blood supply as the tissue heals. This micro trauma is not something you could see or necessarily feel, but that's the way it works. Like I said, it's not something we have a really long history with, but I think it shows great promise. And right now it is available for appropriate candidates.
Yeah. Okay. We've talked about the pain aspect and how a woman, maybe on her own and certainly with the help of her gynecologist, can find answers to the pain. And for the vast majority of women, that is something that can be treated. So talk then about the interest, or as many women will call it, sex drive. Just back to the connection there, and what as a physician you can encourage or talk about on that aspect of her sex life.
Yes. So job one is to make sure that the physical is addressed. That's a full stop. You've got to make sure that the physical, the vulva, the vagina, those genital tissues are healthy and happy and receptive, elastic, not going to cause any pain. So once we have that out of the way, well, a lot of times women are more interested because their body doesn't hurt. Okay, so that's one thing. The other thing to realize is that once you're in midlife and you're not ovulating regularly, you're not ovulating monthly, you do not have Mother Nature's call to reproduce. And that ovulation with the call to reproduce is what made us interested or driven, right? It's a very adaptive thing for mammalian biology, for reproductively able women to want to reproduce. But once we're in midlife, we're not ovulating anymore, then we're not going to hear that call.
Yeah.
So it's going to take a little bit more effort, ladies. I told all my patients this, okay? It might not come effortlessly. It might not descend upon you, but you can have it back. You can get that back. You have to work on it a little bit more. You have to use the woman's most important sex organ is between her ears. It's in her head. That is not to say that any decreased drive or interest is psychological or, quote, all in your head. But the way we view it, the way we think about it, the way we focus on it, the way we anticipate it, the way we plan it, can really get our mind in the right place. And we women are multitaskers. We have 15 windows open at any given time, right? So ladies, we have to close all the windows. The one about the kids, the one about your job, the one about the dishes sitting in the sink, the one about whatever, the relationship issues. You've got to try to really clear your mind. And again, I have no financial interest in this, but there is this marvelous book, and it's called A Tired Woman's Guide to Passionate Sex.
Well, doesn't that fit? Yep.
And if you like most of us, you're too tired. You're pulled in different directions. Maybe you're in the sandwich generation and you're dealing with still kids and aging parents, and your mind is really occupied with very important things. But we have to try to focus our mind, change our mindset about sex, And the book that I mentioned is just marvelous. But let me throw this out there too. It's a very important takeaway for women, really at many ages, most ages, but especially at midlife and beyond. Desire comes after arousal. I'm going to say that again. Desire comes after arousal. So you have to allow for arousal, and then desire can follow, and it's like a very happy circular thing. So keep that in mind. Men are very linear. They're, desire, arousal, climax, resolution. We women are much more complex, aren't we? We're more circular. We can go back and forth.
Absolutely.
Yeah. So keep that in mind. Allow for arousal. So even if you're not in the mood, proceed anyway. And you're probably going to be really happy that you did. Do not make desire a prerequisite to make love with your husband. Allow for arousal, allow for lots of foreplay. More is needed now than you used to need.
Yep.
See where that takes you. Chances are you're going to be really glad you did, right? And the brain, when it likes something, will create more connections that seek that the next time. I had a patient say, it's sexercise. Correct. So in other words, maybe you didn't want to go out on that walk, but man, after you did, you felt really good. And you said, oh, I should walk more often. It's the exact same thing with sex. The more you have sex, the more you're interested in sex. And also the more that those vaginal vulva tissues are kept in good shape.
Yes.
It is a little bit use it or lose it. So I always say, once a week is probably a fine frequency. More is great, less might work, but that's a sort of a general guideline. I could go on and on about interest in sex. And one more thing too on that note is that some couples really, really benefit from seeing a sex therapist.
Yeah.
And there are therapists out there that is their main wheelhouse. Is sex therapy, and they're really excellent at not only the physical, but the emotional, the relationship. We didn't say this yet, but obviously having your relationship be in a good place is critical. Who among us married people hasn't needed some help from time to time with relationship issues?
Absolutely. Every couple does. Yep.
Every couple does. So I would also say, please don't hesitate to seek some help. Sex therapists are out there. They're really professional, good at what they do. And so sometimes that's really helpful too, to kind of rekindle your relationship and have a new take on your sex life. One thing about midlife is that maybe you're empty nesters, or maybe the kids are more self-sufficient, or maybe you're going to retire. And, that's a wonderful space to be in, where you have fewer responsibilities to distract you and a little bit more liberation for your sex life. So I think that's a very happy thing to point out.
Yeah. One of the ways I have phrased something that you've been talking about, Dr. Savage, is encouraging a woman to take a mental step towards your husband.
Yes.
You can choose to put your mind in that direction, and
exactly.
Your body's going to come.
It will. Yeah, you might have to coax it a little bit. But once you get there, once you realize that you do not have to be in the mood to proceed anyway, chances are you're going to get in the mood, right?
Yeah.
And so that's really liberating. So many patients have told me, oh my gosh, I feel so normal now, because I thought modern culture tells us that, the cover of Cosmo and the cover of Glamour, they all tell us that, we ought to be chasing our man around the bed. And if we're not, there's something wrong with us, right? And so I think that if you can normalize the female experience a little bit, it goes a long way towards women feeling much more relaxed, that they are normal. They're normal women.
Great. There's another thing you referenced that I want to just land on for a second also, and that is that foreplay may likely become much more important in midlife, and it takes longer, but that can be a good thing. You can enjoy that time.
Exactly. It is going to take longer. That's a given. I'm so glad you brought that up. You're going to need more time to warm up. We're like an electric stove. We take a little while to warm up, and it's going to take a little longer. Oh, and on that note, lubricant, it's critical. I always say couples of every age need lube, but especially couples at midlife. And I recommend a silicone-based
Good.
lubricant for intercourse at midlife. Water-based lubes are fine. They tend to dry out. Some of them can actually leave you more dry than before you used it. They tend to get a little sticky.
Yeah.
So the silicone-based products tend to be better at midlife and beyond. But I always tell patients, try several, experiment. There are hybrids, hybrid water plus silicone. Try several and see what suits you, see what you like. Use different ones. But I think it's critical because the slide and glide can go a long way towards comfort. It can help foreplay be more comfortable and more prolonged, which it will need
Yes.
to be. Probably 20 minutes.
Sure. Yeah,
Yeah,
just be real. 20
yeah,
minutes is not unreasonable, and it is
yeah.
normal if it takes that for you.
Exactly, exactly. A word to husbands. I don't know if any will be listening, but I want husbands to get educated on this. I want them to understand it's their manly talent. Use it.
Yes.
Things are going to be different now. Things are different for them too, and that's this topic of a different podcast from a different expert. But I think that it's so important that couples work together on this. Husbands sometimes they get their feelings hurt because they feel that if their wife is not lubricating adequately, if she needs a lubricant, if they need a lubricant, that she's not that into him anymore. And it's so unfortunate. It just breaks my heart. I had one patient whose marriage was on the rocks because that's what her husband thought, and it just I was just, my heart went out to her and them. So with a little education and a little bit of real dedication from our spouses, our husbands, our men, to learn about this midlife, to realize that we have a new normal. It can be better than ever, I promise. But everybody has to really be understanding of these things. That there are two people in each couple.
Yeah. Yeah. Thank you for just getting real here, Dr. Savage. And I just want to encourage, if you are a woman in midlife watching this, this is something to talk about with your husband. Have conversations about it. You don't have to wait until you're in bed together struggling. This is something that it is okay to talk about and wise to talk about at other times.
Oh, we should
Make
talk
it
about
one
it.
of
We
your
actually
make it
shouldn't
one of
talk
your
about it. Yeah.
regular. Yeah.
Don't talk about it in the bed or the bedroom. Talk about it over coffee.
Yes.
The book I referenced, she calls it kitchen table conversations.
Great. Yeah.
Yeah. When you're, it's great to be talking during sex, but if you're talking about these topics, making it better, physical changes, etc., how you need to change, how you need to adjust, some of that is better done at the kitchen table and not in the moment.
Wonderful. Dr. Savage, I know you are now lending much of your expertise to Genève. And just a quick moment, if any of our people watching want to connect with that organization.
Thanks for that, Dr. Carol. Yes, I'm doing telemedicine now with a really wonderful company called Genève, Gennev, Genève.com. It is an online clinic for menopause. And not only do we offer telemedicine appointments for menopause management, we have a terrific team of health coaches who are all registered dietitians. They can help with a lot of concerns over weight and metabolism, nutrition, you name it, exercise. They're terrific. We also have all kinds of resources, blogs and articles, videos, you name it, education from a reliable source on all things menopause, Genève.com.
And we'll have that link available in the show notes and under this video as well. Well, Dr. Savage, what a delight to just be able to go there and talk about these things that women want to know and are sometimes afraid to ask. This has been so helpful. And thank you so much for being with us today.
Oh, it's been a pleasure. Thank you very much. I'd love to come back sometime.
Will do.
Perhaps there was one item that Dr. Savage said that you have not considered that can make an enormous difference in your sex life. Maybe it's the silicone-based lubricant. Maybe it's the desire follows arousal and taking a mental step toward your husband, or the prolonging of foreplay, or the vaginal estrogen, which almost every woman can take. So if you haven't had that conversation with your gynecologist, like Dr. Savage, I would encourage you to make a problem-focused appointment. You can talk about it anytime,
But this deserves an appointment, and I'd encourage you to do that. I also want to just comment on the relationship factor. In my work now, as a coach and a minister as well, I hear from women often who are struggling deeply with relationship issues. Difference in desire. Maybe it's your husband who doesn't want to have sex. Maybe there is porn addiction or big anger issues or deep disconnect in the communication between you. If those elephants are invading your bedroom, get some help. Sex is about a lot more than biology. Yes, it involves biology, but God created you as an integrated human being, and especially as a woman. Your body, mind, and soul are all connected. Previous trauma around sex, significant relationship issues, even religious messages around sex can all impact you, perhaps especially in the midlife season when your biological stimulus for sex may change. But this is still an important part of your relationship, and it may be that this is the season to get some help for old trauma or for relationship issues. And if that is the case for you, I want to encourage you that you deserve that. Those issues deserve help. We have some resources available at Dr. Carroll Ministries. We have our Sexpectations course that deals with your sexual story and helping you work through that. We have our Navigating Midlife course, and I would especially like to invite you to that. Navigating Midlife deals with everything that women struggle with in their midlife season. The biology of menopause, the symptoms of menopause, the mental and emotional factors there, feeling like you're going crazy, all the other life stuff that happens. And yes, there's a whole module in the course about sex and sexuality in midlife, dealing with your husband about that and so on. We talk about the people you need in your life in this season, the other life stresses that almost all women struggle with, and then what this means for your purpose, sense of purpose, your relationship with God, your sense of identity. Your purpose is not over if you're still breathing. There is no expiration date on God's purpose for you. So if that is something that you would appreciate some help with, navigatemidlife.com or click on the link under this video. Do check the links under this video. We'll have the link to Geneva, to that Dr. Savage works with, to the Sexpectations course, to the Navigating Midlife course. These are important issues, and you deserve some help. I want to thank you for being my friend and being part of our family here. I'd love to hear from you, and until next time, may God bless you.